And we'll give a few moments for folks to check in here. Hope everybody's doing okay. Looks like here in Portland, we've got our weather starting to change a bit, getting something that looks a little more like proper summertime weather here. Got my garden in last weekend, and irrigation systems all set up in advance of the upcoming trip that my family and I are going to be taking to Italy and Morocco in the month of June, which means we won't be here. Today, we're going to be talking about extension intolerant back pain. And I'm going to add one little subtitle to that, Beyond the SI joint. So we'll talk about a few different common presentations clinically that tend to show up. I'm talking about this week because it seems that in the past week or two, I've had a increased uptick in the number of patients I'm seeing with a variety of these. And I thought it would be helpful to discuss decision-making process and screening to try to ferret out specific tissues and functional patterns that are associated with so-called extension intolerance. Intolerance, before all the haters over here on social start to jump in on the intolerant remark. The intolerant remark doesn't mean that the spine's not made to extend, doesn't mean it's not made to move in different directions. It just means what at a given time it prefers to do or not do. You could just as easily insert some of Peter O'Sullivan's terminology here and just call them an extension pattern of back pain rather than an extension intolerant pattern of back pain. So all of those things are valid. Now, a little bit of commerce to start with. The NeuroCentric Approach Online Academy is available to you. These people that are over here are already on it. They're already members, and they can come and join me on a Zoom, and we can talk shop on a regular basis and get a little deeper understanding on the NeuroCentric approach process. Those of you over here on Facebook can join that by going to neurocentricapproach.com and look for the links for online courses. The online academy is 35 hours of continuing education and a community where we workshop things throughout the week, but once a week typically, we get together like this, 9 o'clock Pacific time on Zoom and talk shop. The other perk that you get as a member is you get $100 off of in-person coursework. And the in-person courses, our next one is in July in St. Louis, and we've got one now scheduled in Phoenix in December. I should have that registration page up this weekend now that I've gotten all of the P's and Q's together with that. Good morning, Dr. Heller. And those are our online our in-person courses. And as I mentioned, as a member on the site, hello, Jerome Pryor. Good to see you, mate, and congratulations on your son's success with funconometry, Canada's Got Talent. You get your nice perk of $100 off with the membership there on the site. Let's see. I don't think there's old business beyond me just mentioning once again, I will not be doing this for the month of June, as we are going to be my family and I on a trip abroad. So we'll catch you in July. We'll still be here next week as well, though. Okay. So let's talk a bit about extension intolerant back pain. And I mentioned beyond the SI because those of us that are trained as chiros learn to adjust the SI joint 6 ways from Sunday. We learn to name various SI presentations, and just off the top of my head, I can remember 3, 4, maybe even 5 different nomenclature naming systems for how that dastardly SI joint can get in bad places. I think it's always important if we're going to talk about the SI joint to acknowledge that it really doesn't matter all that much by it really doesn't move all that much by nature's design. Jerome's on here and can talk a bit about that, I'm sure, at some point, perhaps. Fiber cartilage on one side, synovial cartilage on the other side, tends to wear with a characteristic groove pattern. I always used to say to patients back in the day that, yeah, you can get a bit of trauma through the joint and wind up in a position that you don't favor, perhaps. And in those cases, maybe a sacroiliac joint manipulation would be worthwhile. Jerome's showing us the sacrum there in a picture. Jerome, why don't I open things up for you here and talk to us a little bit about the sacroiliac joint. Let me see if I can get you up here on camera, my man.
Can you hear me?
I can hear you. Yes. All right. What do you got there? It looks like an authentic human sacrum.
It is. Yeah. And I thought I'd just bring this to the viewers. I wanted to show kind of the size of the joint. We'll get some scale and how undulated it is. So it interlocks. You can see that it's not a right and not a kind of a smooth, convex and concave surface, right? So, and you can see we've got some differences from left to right. Right. So this is a natural specimen. I could actually let me grab another one. But I appreciate you thinking that perhaps I know some things. But I'll leave that up to you, Phil. Now, this side, just remind me again, this side has the hyaline cartilage, and the other is the fibrocartilage. Is that correct? I've just kind of forgotten now.
I got to be honest with you, I'm not entirely sure myself.
Okay, so anyways, it's a very interesting joint, of course, right? Let me see if I can grab another specimen here. Just going to see if I can prop this up for you guys so while I disappear. Let's see what else we have. What else do we have?
Yeah, one of the things that I've noticed over the last several years as well is a pretty dramatic uptick these days in our physical therapy brethren engaging in SI joint hijinks. It seems like it's become a pet joint in the world of physical therapy now, much in the way that it was historically in chiropractic. And I'm not entirely poo-pooing the benefits of a sacroiliac joint manipulation in a well-chosen patient population, but I do have that it happens. It's seen as a source of some sort of discomfort and pathology far too much.
Yeah, I have I think, as we were trained as chiropractors, we were trained that there were so many different ways to adjust the sacrum or the SI joint. And there was a paper published. I'd have to go dig that up, but that, when we do the side posture manipulation and we place, our forces, our manual contact on the sacrum, or if we on the PSIS, logically, I think logically we're going to be seeing this joint gap first. This is likely, we think this big articular joint that's held in with so many ligaments, and there's very minimal movement with it. By rotation, for the most part, this one will gap first. And if this one's this is my opinion, and if this one is restricted, L4-5 will pop first. All right. So I think, we think we are being so specific, but I think the path of least resistance will gap first.
Rome, let me ask you, have you been to view any joint block procedures for the SI joint?
I haven't. No, have you?
I've not, but in the description and talking with physiatrists to do that kind of work, I could see a lot of room for we'll call it sloppy technique, perhaps. I see a lot of mileage made out of in the world of physiatry, joint block procedures to the SI joint or to the facet joint to quote unquote definitively rule those joints in or out. And yet I see that it's not terribly uncommon for the technique procedure before the needle actually pierces the joint for a bit of the anesthetic to be released, and then on the withdrawal for a little bit to be trailed out such that you get some anesthetic in a surrounding area of the joint as well. And I see that, and see when I talk with those docs and see the possibility that these definitive procedures, there's a lot of room for error, and we still probably need to keep our skepticism involved here, even when we see that, and probably also ought to keep our bias in check.
Yeah, I agree. I think for me, the best sort of way to test to see if an SI joint may be a symptomatic structure is to get people, we don't have, access clinically, within our walls, but I just get people in an SI belt and I just crank it right up, right? A Ciroli belt, and I just crank it up as tight as somebody can tolerate. And then I get them to, reproduce the movements that cause symptoms, like, getting out of a chair or whatever, movements that you can do pre and post, with and without the Ciroli belt. I think for me that's a reasonable approach. So
yeah, I'm inclined to agree as well. So let's see, Mark's tossed something into the chat room here, which got
I just wanted to show you, this is a 5-year-old specimen. There's a 5-year-old sacrum.
Oh wow. Yeah.
So I just wanted to show you, right? Look at the SI joint, it hasn't even formed yet, really. But there's an early development of one.
that, and seeing it as well as the joints still not having fused as well, and S1 to 5. That's pretty cool. Mark tossed into the chat here, I have a recent case, negative on injection, positive response to the belt, positive provocation test. Let's get Mark on. Yeah, talk to us about that, Mark. What do you got?
I have a recent patient in really nasty pain for quite a long time, and she had a few 10 years ago. She had a problem with L5S1 and had a discectomy that was successful, but did leave her with weakness of the L5S1 muscles, the toe dorsal flexors. But basically, I kind of crashed and burned on the first couple of times I saw this lady. And then on the, she sent me over all her chart notes, and her, one of her doctors who did a nerve conduction study said something about, oh, I think you have an SI problem. And she did go and get injections, blocking injections, and it didn't do her any good. But then that third time I saw her, I poked around. The SI was tender. The provocation tests were positive kind of universally. And the interesting part is I was listening to Jerome and the Sorolla belt story. I did not have the right size SI belt for her. So I took a yoga strap and strapped it around her pelvis. And she said, oh, that feels so much better.
Yeah.
And I'm ordering her, or I told her to order the OPTP belt. So anyway, so that's the little mini story here with injections can be imperfect about this stuff. So, and the other part of the story for me is for a long time, I thought that the SI was not a player unless the person had positive provocation tests. And then when I couldn't get over an injury, a twisting injury I had shoveling snow, I went to my physical therapist friend who does osteopathic muscle energy. I thought for sure I had re-irritated my disc. He realigned my sacroiliac joint in the way he does it, and 3 treatments of that, and my back was okay again. So it's like, and that's made me skeptical of the whole thing of saying you absolutely have to have positive provocation tests in order to address the sacroiliac. I'm kind of like back into, hey, I'm paying attention to sacroiliac a lot more again.
Do you think, though, that with the procedures that your physical therapist did, that other structures could also be coming along for the ride in that might not have anything to do with the SI joint?
Absolutely. And for sure, it's like Jerome was just saying, you do something to the SI and you're affecting the L5S1 and probably the L4-5 joints as well. So, yeah. And I kind of, for a long time, my drill was, okay, it's really obvious that your ASISs are not even and your sacrum is not even, and let's take care of the Mang syndrome stuff. Let's take care of your discs and see if that stuff realigns. So, I had years of doing it that way, and with mostly good success, of course. But anyway.
Yeah. Many of us have certainly played that SI card relatively successfully over the years. I think the place that got me really starting to think about it was relatively early on in practice in the first few years. I remember having one of those SI patients that I had seen. And, you know, they were one of those that came in with their little out card, right? You remember the patients used to carry around, and it's like they had their
Travel
vertebral.
card. Yeah,
Yeah,
as if they have the same subluxation every single time they go to the chiropractor.
yeah. So they carry that around in their wallet, and you know, when they travel, they can pop in and see somebody. And I wound up with one of those patients showing up after their doc had retired. And so I just gave them what they came in for. That's what I'd been trained to do. And I manipulated that SI joint. I manipulated that SI joint. I manipulated that SI joint. And I did it, you know, in the way that they have been trained. It was good business, right? It was, so they came in, you know, weekly, or, you know, every, I don't know how long it was, monthly or whatever, but I saw them several times, manipulated the SI joint. They were quite happy with it. They'd come in pain, they'd leave without pain. Peace, love, and guitars, right? And I didn't see him for a good long period of time, like a year. And they popped back in. And I said, oh, you know, I see, I haven't seen you in a good long period of time. You been okay? And they're like, yeah. You know, something really weird happens. I had a back pain episode that was remarkably different. It was just, it was like kind of pain I've never experienced before in my life. And, you know, not only was it in my back, but more importantly, and even more noticeably, it was really painful in my leg and down in my butt. And it was this searing hot electrical pain. And she's describing a radicular process. And, you know, I said, well, how did that come on? Did you have any kind of a, you know, a lifting injury or anything that kind of provoked it that you can recall? And I'm like, no, nothing really happened. I just kind of woke up one morning and bent down to pick up my socks, and I had this searing pain all the way down to my foot. And I'm like, well, damn, why didn't I see that? You know, because you would like to think that would be a herald. And then I started to ruminate on that, as a young doc will do. And I'm like, you know, maybe that SI joint was actually a herald of something else that was going on. And that got me thinking a little bit differently, and maybe more deeply. I don't know about this. But with all of that in mind, I want to talk about a few cases that I've seen recently. One is a chronic pain patient that I mentioned recently, 72-year-old male. He had an SI joint fusion. He's been in chronic pain, a classic failed back patient. He's had, I think, 5 different surgeries on his lumbar spine. He was a college soccer player. And in the 1980s, had his first radicular episode, and then subsequently had a laminectomy, and then a fusion, and then revisions after tethering of the nerve root with scars. And you know, they had, at this particular point, its quality of life has been incredibly impacted for 30, almost 40 years now. And his his most recent procedure was an SI joint fusion last year at the age of 72. No change in his pain. For what it's worth, is our functional approach right now that we're working, and I'm leveraging mostly a DNS card there because he has practically no strength. And, you know, he can barely move. He can only stay upright, either sitting or standing, for 4 hours a day before it's intolerable. And he spends the rest of the day laying down. And that's been his pattern for a number of years. So, you know, if for that particular patient, stabilization exercise is the route that we're playing. And I'm using more of the stabilization kind of calling card that Hicks et al., and part of that et al. Was Stuart McGill. We'd be playing McGill's work with some of the DNS work as well, and combining those two approaches. But another one recently that I've been dealing with is a young, very young patient, 18, high school, with a MRI demonstrated L5-S1 disc herniation. And she's had the full gamut from what I've seen. The herniation is a lateral presentation. The lateral presentation will tend to present with a lateral antalgia, and to my mind, that lateral antalgia places those interesting, perhaps unequal forces across the SI joint that can cause perhaps a bit of a pelvic upslip, as the QL on one side will tend to be a bit hypertonic. And that pelvic upslip on that side, and some of the classic listings would make that an AS ilium on that particular side. And the hypertonicity on that particular side also causes some palpable tenderness over the medial branch of the superior cluneal nerve. So with her, we're dealing with a disc that is flexion intolerant, but she's got a combo platter. If we extend her, the impure extension, that lateral presentation doesn't like it very much, and the superior cluneal nerve doesn't like it too much. So she has been a very difficult case to manage, because it's almost like playing whack-a-mole with her. And we've had injections with transient benefit, and mostly I've just been training her around these episodes to improve her stabilization capacity in the low back as well. But just a terribly difficult case to try to manage, because it's like I'll get 3 good weeks of very good work with her training, and moving her up from a strength program to a power program, and then we get her running up to 100%. I saw her and she was running at 100% capacity, and then she went and sat on a plane for about 6 hours and flared up with her disc symptoms. Prone press ups are no good. We got to do the lateral McKenzie protocols and do the lateral glides, and then once the lateralization clears, then we can move into extensions and all. So just a bit of frustration there. So what I've come up with over the years, and one of my courses, I can't even remember which one now. I was just looking for it a moment ago. Wanted to pull up a graphic, but I did a chronology of what I most commonly see in these patients, in most of our back pain patients over time. And far and away, what I see most commonly is that in a younger patient, the most likely structure in a back pain patient that's going to be talking is commonly, I won't say far and away, especially owing to the recent paper that showed that close to 50% of our adolescent athletes that have back pain actually have a pars fracture. And that number kind of blew me away. But in many of those youngsters, we're dealing with a disc of some sort. If they're a rotational athlete, the lateral presentation is much more common in that disc presentation. In the younger patients, according to Michael Adams' research with his wife, in those younger patients, the disc injury is much more commonly going to be in the upper limb. And in the older, as they get a bit older, the disc is much more likely to be a lower lumbar issue. just reading Jerome's chat stuff there. We can follow up on that in a moment, Jerome. But what I generally see is the injury in most backs starts off as a disc in the lower lumbar spine. And because of the injury in the disc, we have a reduction in hydrostatic pressure in the motion segment there. And that allows a bit of extra shear, which Jerome could speak to as well. And he's modeled quite nicely in his work with dynamic disc designs. That allows for extra shear at that level. That shear, increased shear, is what gives us what we are starting to see as a much more common presentation than perhaps previously we've been trained to think of as a functional instability at that motion segment, at least for a period of time. And it from the cellular level all the way out to gross histology at muscle and joint level of histology, everything in that area from the cellular strata at the annulus, the strata and the nucleus, everything is attempting to become more stable. The stiffness increases in that area, seemingly by design to try to take care of that functional instability. Now, the other thing that happens when you have a loss in that hydrostatic pressure is the facet joints bear a lot more load, especially with any kind of extension. And you couple that with the protective tightening or hypertonicity of the lumbar erectors, and now you've got a person that with that disc injury that walks around for a number of years with an anterior pelvic tilt and lumbar muscle hypertonicity and possible tissue acidosis that causes a secondary source of nociception there in the muscles, and potentially in the superior cluneal nerves that reside in those muscles. So in that chronology starts as disc. Relatively soon after that, the adaptive postural splinting can cause involvement of the superior cluneal nerves and the extension effects at the upper lumbar spine that can cause our Mainz syndrome. Over a period of time, that particular patient with that unexplored or underexplored will have some changes in the mechanics of the hip joint, and then the hip joint becomes problematic, and now you've got potentially gluteal pain that could be of hip origin, could be of sacroiliac origin, could be of SI origin, could be of facet, of cluneal origin. Everything could make that better. Then you got to do your deep gluteal pain syndrome strata, all of that. So that's a lot of the fix your own back course and the lower quarter NeuroCentric approach course. Now, over time, those facets bearing more load, and I think probably Mark with his older disc herniation, and certainly me with mine, can attest to, is that I've become a hell of a lot more extension intolerant and a hell of a lot less flexion intolerant. And I can move into flexion quite a bit more now. But I'm still loath to do that under load. I'm not going out and doing Jefferson curls. But these are patients that might be cruising online and looking and seeing that Jefferson curl as a possible option there. And as we've mentioned before, I generally would prefer to do that by taking compression a little more out of that equation by using a supine DNS kind of log rolling stimulation of the deep abdominal muscles and the lower abdominal muscles to try to get a little less of that anterior pelvic tilt and a little more of a centered position on the pelvis. So I generally see that to be what starts off as a flexion intolerance over time turns into an extension intolerance, and then the structures that could be involved. If they're much younger, I'm thinking more lateral presentation on the disc and possible SI involvement. Independent of age, I'm going to screen for the SI joint. As they get older, I'm much more bullish on the facet joints, much more likely to do engage in manipulation on that particular patient. And that is consistent with the clinical prediction rule that was put together by DeLitto and Fritz and Hebert a number of years ago, Jeff Hebert. So that's the way that I generally approach these and trying to make sense out of these cases. And sometimes you get patients that are kind of in betwixt and in between there. You just got to roll with it empirically for a period of time and trial something. I do recall, one of my former co-workers, Dr. Bruce Chaser, clued me into a manipulation he used to do. He called it the anatomical listing for it was an anterior sacrum. So the sacral base theoretically being pitched a bit anteriorly there, but the setup on it, and I found the manipulation to be very well enjoyed by our older patients. It's a side posture and it's a scoop on superior to inferior tissue pull just broadly on this the sacrum, and trying to put a little bit of counter nutation on that sacrum, and I've found that to be helpful for a lot of those particular patients. So now, we've got some long in the tooth docs on here. You guys have seen a lot of these kinds of patients over the years. Any thoughts, anything that you want to share there?
The one thing I want to share is that if the provocation testing to me says when I put more motion into the sacroiliac joint, it causes pain. I think that tells us don't do heavy duty side posture manipulation of the SI. And I don't think this group is probably that way, but I suspect that most chiros, someone comes in for the low back, they end up getting a side posture manipulation. And I think that has more chance to irritate a truly painful SI than to help it. And if they, God forbid, they have already a herniated disc, there's some risk that we're going to make that worse also. So I'm back to learn low force methodologies of moving those joints. So enough said on that.
Yeah, I'm inclined to agree with you, Mark. And I think a generally good principle is to start with lower force, lower risk techniques for in all of our patients, but certainly for those where you, if you're wrong, you could potentially worsen the condition significantly. I'm just going to play devil's advocate though for the, I don't know, PRI trained people or even classic chiro trained people, and maybe ask if Jerome wants to weigh in on that, if you still got your ears on, Jerome, about the classic bone out of place model, because it always seemed that people leaned on that very heavily in those systems, with the idea, as I was mentioned earlier, that owing to that interesting configuration of the sacroiliac joint, we can literally wind up a little bit out of your groove, and a quick little nudge in that particular area seems to be quite helpful for people. Jerome, what do you think there? Let me get you unmuted. There we go.
Great questions. You know, so, you know, I don't even know where to start. There's so much in my cortex.
I
You
threw you
know,
a softball there, buddy.
yeah, what do you, is there something specific you want to ask me? Like,
No, I want to know if you have any opinions about a classic bone out of place model on the sacroiliac joint.
so the sacrum's out of place or the ilium is out of place?
Yeah, yeah. I mean that any kind of contact that we would be doing to shove the sacrum or the ilium in any given direction with a therapeutic goal to try to level the, as we hear all of the time, the hips that are out of place.
Oh gosh. So likely not. I'll just be frank about it, right? You know, you might be able to nudge the hypermobile joint in a particular direction and hope to bias it in a spot that may be less symptomatic. You know, working through some other functional strategies using muscles and things, but the actual like gap the SI joint to fit into a new slot that's subluxed, highly unlikely just based on the anatomy. It's just straight up. There's like, we've got to be reasonable with our thought processes here. That's the way I feel anyways.
Got it. So if what is it about the sacroiliac joint that you think anatomically makes it less amenable to that movement? Is it what you were talking about before, that the general processes and positions that we put our patients in are much more likely to cavitate the L5S1 or L4-5 joints
Correct.
before we get that beast of a joint that you're showing us right there to actually cavitate or distract?
Yeah. Yes, absolutely.
Got it. Okay. So we just put a heel lift in, right?
Yeah, it's you know, it's tough.
I'm gonna get us all in the chiropractic hot water here.
Oh, it's okay. You know, it's okay. We've got to move, you know, we've got to move forward with these ideas, you know. I know our training, I'd be very interested to move through the whole DC program again and see what they're pushing. You know, it'd be very, very interesting, right?
I've actually thought about going out and auditing classes and just sit in the back and see where we are now with some of this.
Like, you know, I you know, I understand. You get somebody inside, you know, they come in and they claim, oh, I got an SI problem. I need my SI joint adjusted. My hips are out of place. Okay, we're going to get you on your side. Oh, wow, look at that. Okay, oh, that feels way better. Thanks, doc. Cha-ching, away you go. Like you said, there are other things that are happening in the room, and we have to be mindful of. You even just explained a case about, you know, likely it was a, you know, L5-1 or a 4-4-5 disc that was symptomatic, and we keep pushing on that, and luckily we got a pop and we get a gapping of the facet joint. We know. Let's just go back a little bit with regards to, you talked about hydrostatic pressure and shear, right? And now you moved into an older patient that's got arthritic facets, you know. So, you know, the act of shear, for me, I was kind of, you know, they didn't teach us much about shear. right? They didn't teach us about these movements related to that. And it took me a little while to understand the concept of shear. I just wanted to share with people here that when you lose a little bit of hydrostatic pressure, likely because the nucleus is now migrated into, it's not in a contained space, it's now moved into the annulus, and the hydrostatic pressure can't be sustained because now the nucleus has more volume to move into. You're going to lose disc height, and now you've got this disc that's moving around more so, and the shear that you talked about relates to now you've got the facets that are bearing much more load. So I just wanted to share that with people. And when we gap, and now the facets are symptomatic, and if we gap a facet joint, well, guess what? Now you've increased laxity in the facet joint. Patient walks out. Oh, wow, yeah, that feels much better in the refractory period. Okay, where do I pay? Okay, great. Now they sit down in their car and they go into flexion. All right. Oh, you know what? Feels good. Oh, yeah, that chiro, he's awesome. Right? He is so awesome. Oh, I felt a little bit when I got out of the car. Oh, it must be just part of the whole experience. All right, so I get, well, you know what? Well, it feels pretty good. Now you're still within the refractory period of about an hour. It could be an hour and a half. If the joint continues to move, the refractory period likely, based on the research that I've done, expands. So it extends. It can go, within the 20 minutes to now an hour. If you keep a joint moving after it's been adjusted, it doesn't, the refractory period will increase over time because the little bubble doesn't get a chance to kind of suck away with the little pumps that are happening within the synovial joint. So yeah, I know there's a whole clinical experience with our patients it's very interesting. We're thinking we're doing one thing and we're often doing something else. And that's why I developed these models to help us just be a little bit more clear on what we're approaching and targeting from a therapeutic standpoint so we can understand symptoms. I just, I don't want to take up your space here and all I want to be is helpful, but I just wanted to, the research that I did back in 2010 using upright MR, looking at offloading the disc. Okay. So if you have a patient that's like, oh gosh, I got to go on a plane ride, and they're worried about it because often prolonged sitting is going to flare them up. And the research that we did was we looked at an offloading strategy where you use your upper extremities, basically your shoulders and your arms, to basically increase the disc height by pushing down on the seat back or on your armrest, holding it for 5 seconds, and just pumping this reduced hydrostatic disc up a little bit. And if you can prevent this thing from, I'm going to say, bottoming out, but it's not really bottoming out, but at the bottom part of the disc height loss, and keep it just pumped up. I've had so many patients tell me that, previously in long plane rides, they would get symptomatic, but if they offload periodically, then this thing doesn't bottom out. So anyways, that's enough of me.
No, that's really good. That might be worth the price of admission here for any of the viewers on this and worthwhile for this to be out there as a something that people can see as a recorded item. Which, by the way, you guys record these and they reside on the NeuroCentric Approach blog, and you can find those. And also on Facebook Live there for a period of time too. Jerome, thank you. That was helpful. And I can see that already we're probably going to start seeing a whole lot more people if we get a little exposure on that. A lot of people doing that offloading procedure on planes. next to us. Now we just have to fight over who gets the armrest and when in order to do that. All right. So that's about all I've got for this week. Unless anyone's got any questions or comments, I think I'm gonna head to my next project, which is gonna be some plumbing today. So lucky me. Guys, take care.
I just want to thank Jerome for all that he adds and appreciate him being out here and showing with the models. And thanks a lot, Jerome.
Yeah, it's nice, very nice to have you on board with us, Jerome, and giving us an opportunity to see your incredible body of work that you put together there. It's very impressive what you've done, mate.
Well, thank you. If I'm still on here, I'm just trying to contribute and make more sense for our patients.
All right. Well, to all of you that are watching, either currently or by recording, I would encourage you as always to remain compassionate, stay curious, take what you learn and go help some folks. Be well. I'll see you guys next weekend. Take care. Bye-bye.